Hello, good evening, everyone. I hope all of you are here. We will just begin in a minute. And yes, I hope my voice is clear for all of you and it is loud and clear. And I believe there is no disturbance around me. Can someone please confirm that in the chat? Am I loud and clear? Is there any disturbance here? All right. Good evening, Dr. Mashta. Yes, thank you. Thank you so much. Just a second. Okay. And we are going to start the lecture shortly. I'm just here to inform you a couple of things, and some of you are our subscribed people and some of you are from our free group. You are most welcome, first of all, to this lecture series. Okay. Just a second, I'll just change my color. It doesn't look much appealing. All right. This is an initiative from us, from MedExam Expert, that every day, that every day we want to, every alternative day, in fact, we want to interact with you all, and we want to just take short lectures for part one PACES candidates on various topics. So today we are going to start with rheumatoid arthritis, and we will be doing most of rheumatology topics. And one doctor has requested for topic on Hep B and C, which we will be taking shortly, maybe tomorrow or day after one the days I will be definitely doing. And if you doctors need any topic that you are finding it very difficult to understand, okay, please ask me. I'm more than happy to do that. Please don't ask me biostatistics, because it's guaranteed if you're going to learn biostatistics like topics from me, that's going to be a failure. I'm not kidding. I'm just telling the truth. All right. We will begin in a second. Just give me a second. I'll just adjust the audio. We will start. All right. So this is what we are going to do. You can't hear because I was actually not speaking anything. Okay, Dr. Sanjita and Dr. Ashik, good evening, good evening. You're most welcome to the lecture. So like I said, as I requested, only one thing, that is, if you guys have any doubt on any subjects which you feel difficult to learn or difficult to understand, you guys are most welcome and more than welcome to ask us. One doctor requested a topic of hepatitis B and C, which I'll be taking, and I'll be just continuing some topics on rheumatoid arthritis. And today and tomorrow, day after, we may be just looking at ankylosing spondylosis or other psoriatic arthritis, other inflammatory arthritis in general. All right. And this is mostly for part one, part two, and PACES candidates as well. There are certain parts I'll be concentrating for people who are going to appear for PACES. How many PACES candidates are here? Anybody here who's prospective candidates for PACES examination? Can you please tell me? Please type in the chat. Please don't turn on the audio because it's being recorded. Can you guys please type in the chat prospective candidates for PACES examination? Anybody is here? If anybody is here, please say just a hi. Of course, all of you are going to attend the PACES examination without any doubt. All of you are going to attend the PACES examination. But if there are anyone who is now all set for PACES, please let me know. Okay, I'm more than happy to help you out. And if you guys are around the place where I am located right now, you can come and visit our hospitals. You can see the patients. You are welcome. No need to give me anything. We are doing it philanthropically. All right. Okay. Nobody's up for PACES now. Fine. I'll just go ahead with the class. This is a typical case of rheumatoid arthritis. What you will get, typically a lady of 52-year-old, and There may be 2-month history or more than that, bilateral hand and wrist pain, swelling in the fingers. She has also recently noted any similar pain in the balls of her feet. She finds it hard to get going in the morning, and there will be always there is going to be stiffness for more than 30 minutes or more than an hour. She also complains of increasing fatigue and is unable to turn tabs on and off or use a keyboard at work without significant amount of pain in her hands. And she denies infections before or since her symptom has been stopped. This is a classical presentation of inflammatory arthritis. All right. This is how classically an inflammatory arthritis will present. That's what I wanted you to know. All right. Now, coming to rheumatoid arthritis. What is the etiology? Okay, every point here is an MCQ pointer for part 1 and part 2 and a question for PACES candidates. Doctor, can you tell me something about rheumatoid arthritis? Can you think what are the possible causes behind that? You should be able to tell. The very first thing is a positive family history. It has around 2 to 4-fold increased chance of getting rheumatoid arthritis in subsequent generation. All right, that's the very first thing. And the second thing, I want all of you to remember one particular name is DRW4. It is the most commonest genetic abnormality associated with increased rheumatoid arthritis. The third thing I want all of you to remember is IL-6 promoter polymorphism. Why I'm telling this in detail is this is more common in Asian populations, especially where you and I are living. All right. Apart from that, environmental factors such as the smoking, overweight or obesity also associated with increased risk of rheumatoid arthritis. All right. I hope all of you got it. Family history, DRW4, IL-6 promoter polymorphism, and smoking, overweight, obesity. All right. For both part 1, part 2, and PACES, same thing. If your part 1 and part 2 is good, you won't fumble when questions are asked in PACES. All right. Next, key factors in history and examination. What things you will know in the history? Maybe in a question or maybe when you're seeing a patient directly, there will be active symmetrical arthritis. Typically, you will find a person who is age 50 plus. Of course, juvenile onset rheumatoid arthritis is also there. There is no doubt about it. Okay. Female sex. Most of the autoimmune diseases are most common in females than men. Okay. Most autoimmune disease. I'm not going to go into the genetic details because I don't like teaching anything that is irrelevant and unwanted for your best interest. Okay. Joint pain plus swelling can be there, and stiffness more than an hour. And there are deformities like Swan neck and Botonius deformity, and as well as ulnar deviation. I'll show you the pictures. Okay. This thing. Forget this. This is not the Swan neck deformity. Swan neck deformity is something supposed to be in the distal interphalangeal joint, and in the proximal joint, it's a Botonius deformity. This is an ulnar deviation. I'll show you a better video of my own patient. Okay. Other things, what you will see is rheumatoid nodules. You will find vasculitic lesions. In lungs, there are a myriad of findings you can find. The most common thing in lung is your good old pleural effusion, rheumatoid pleural effusion. Okay, the rheumatoid pleural effusion. It's the most common thing in lung, followed by fibrosis. It can be basal and apical fibrosis as well. All right. Basal typically due to when the drugs like gold is used, which is obsolete now. We are not using gold anymore. And apical fibrosis in your lung apex, if the fibrosis is that's classically due to all. All right. Then hypersensitivity pneumonitis due to methotrexate. Earlier days, there was a teaching methotrexate causes fibrosis. But more than fibrosis, the most specific thing that it causes is a hypersensitivity pneumonitis. And then bronchiolitis obliterans, pleural thickening, and pulmonary nodules. Rheumatoid arthritis can cause nodules anywhere in your skin, your pulmonary nodules behind the ears, almost just anywhere. Okay. So this next 2 slides is for PACES people. Nobody is there, but I'm still bound to teach. Apart from that, it's common for everyone. And there is nothing wrong for part 1 and part 2 people to learn this, because you are also going to give your PACES examination, hopefully by God's grace at the earliest. Okay. Always in a hand examination, place a pillow below the hands. 3 things. Look, feel, and move, and be as gentle as possible to the patient. Please ask, I'm going to just touch your joints. I'm just going to move it. If any point of time, if there is going to be any pain or discomfort, please let me know. Be gentle. Just touch for one. Just see the hands. Swelling of MCP, any PIP swelling, or there any guttering of intraossei, subluxation, and ulnar deviation, any swan neck deformity. Swan neck is what? See, this is a swan. Am I right? Okay. When your distal interphalangeal joint is affected, I'll show you a video. Don't worry. This is a typical swan neck deformity. Okay. Flexion of the DIP and hyperextension of the proximal interphalangeal joint. This is a swan neck deformity. All right. Botonius deformity, Z thumping, or any rash, scars, or dactylitis. You know what is a dactylitis? When the entire digit is swollen, it's called a dactylitis. This we will see in psoriatic arthritis. I'll show you some patient videos of psoriasis, which I came across. Then comes the palms. Always look for any palmar erythema, muscle wasting, any scars, all these things you have to look. Then look at the elbow. Elbow, what exactly you are going to see, doctors? You're going to look for nodules. Any psoriatic plaques is there, because many times 2 to 3 different types of autoimmune disorder can present in one patient. That's horrible, but it can occur. Then gouty tophi, scars, any bursitis you have to see. Second, after looking, you feel for the joint, see for warmth, tenderness. If the patient is complaining of pain, stop examining the patient. Tell the examiner, patient is having pain. I will tell not to continue anymore. All right. With the pain, if you're going to examine, you are going to lose marks, especially in patient welfare. Okay. If welfare, you lose the mark, you lose the exam. Right. Be very careful. Palpate for joint, wrist for tenderness and swelling, and then feel the pulse. Check for both radial pulses and offer blood pressure. That's very important. Third is move. Ask to straighten the fingers fully, ask to do a prayer sign, a reverse prayer sign, ask them to pick up some objects, ask them to oppose the finger to the thumb, ask them to grip your fingers tight and squeeze it, check for pincer grasp, and offer to see blood pressure. Like I said, it's very, very important. Okay, very, very important. Check proximal muscle weakness. Then further go up, check for lymph nodes and thyroid gland, because all of you, I believe, know something called APS. What is APS? APS is, if the patient says he has pain, you have to stop it then and there. Turn to the examiner. Patient is having pain. Sometimes examiners will, you don't need to examine anymore. Leave it. Then go for other parts. For example, if I am the rheumatoid arthritis patient, doctor, you are examining me, and by the time you are touching my proximal interphalangeal joint, I'm shouting, "Oh, doctor, it's hurting." You have to stop. Sorry. Can I continue? Ask both the patient and the examiner. The examiner, like, be gentle and continue. It's fine. If the examiner is going to tell you, please leave the hands and examine the other systems. For example, rheumatoid arthritis, you have to examine multitude of systems, multiple systems. You have to go there. But never, the moment patient grimaces or winces or says he or she is hurt, stop. Never ever examine over that. Clinical welfare gone, the entire exam is gone. All right, sorry, patient welfare is gone, the entire exam is gone. Then check for pallor, icterus. What I was telling, yeah, APS. APS means autoimmune polyendocrine syndrome. There are 2 types, APS 1 and 2. This rheumatoid arthritis is associated with APS. So it is also associated with other syndrome, other different disorders in the APS. That is like a hypothyroidism. So you have to check for the glands, thyroid glands. Check for pallor, icterus, tongue, look for any candidiasis, discoloration, oral sores. Check for oral hygiene. Okay, check for oral hygiene. It's very important. Look behind the ears for any rashes. Check the hairs for any alopecia. Also any psoriatic plaques and dandruff. Then auscultate both the bases and apex of the lungs. Check for loud P2 due to rule out pulmonary hypertension. Then also palpate the abdomen for splenomegaly or any organomegaly. Look at the legs for any pyoderma gangrenosum, vasculitis, and finally check for pedal edema. Then your examination is done. You have to practice at least weekly twice till your PACES exam, at least for 5-6 months or 4-5 months. to get this sequence in hand. If you leave me now, I'll finish the entire sequence in 3 minutes and turn back. Because I just would have like examined around 300, 400 patients in the last one, this year itself, when it comes to rheumatology for some of the PACES cases and as well as for some PACES videos. So this is how you have to do. Now, all of you are here. Can you guess what is it? What is in the screen? Just a work. Just mind work. See what is it. What is 1? What is 2? What is 3? Just connect it and tell me. You have to tell me what is 1, 2, and 3. And tell me what is it. What you are seeing in the screen. It's too much lecture will be boring. Like, we have to be interactive. I want to be interactive with you all. Can you guys tell me what exactly you are seeing in the screen? What is number 1? What is number 2? And what is number 3? Come on, you guys did not think so much. Number 1 is rheumatoid arthritis, obviously. Anyone good in hematology? What is the cell? Yes, first RA, very good. Number 2, see the abdomen, doctor. You know one thing, in PACES examination, just...
Felty syndrome?
Yes,
Felty.
yes, yes. Yes,
Splenomegaly.
yes, this is splenomegaly. Inspection carries the most. See there, what is that? This is the right side of the patient. This is the left side of the patient. Can you see a mass? This is a passive splenomegaly. It is crossing the umbilicus and going. This is splenomegaly. This is a neutropenia. This is a Felty syndrome. All right. This is a Felty syndrome. Okay. What are the extraarticular manifestations of rheumatoid arthritis? Everything you should know for all 3 parts of the people. It's very, very important. Fever, any lymph nodes, weight loss. That is a systemic. In skin, palmar erythema, any rheumatoid nodules, vasculitic rashes, vasculitis, Raynaud's phenomena, pyoderma gangrenosum. And that's not a basophil, that's neutrophil. There will be neutropenia. Neutropenia will be there. Then pyoderma gangrenosum, scleritis, keratoconjunctivitis sicca, scleromalacia perforans. These are all ocular manifestations. Now, right now, it's a short lecture. I cannot go in detail about all these things. This is all covered in our ophthalmology lecture. I have taken the lecture, you can see. And musculoskeletal system osteoporosis is extremely, extremely important. And osteoporosis is a very, very important topic for all the 3 parts people, for part 1, part 2, and PACES people. So you should know how it presents, you should know the investigations, you should know the management, and you should know the adverse effect of different drugs that are used to treat osteoporosis. Yes. Then in cardiac, it can cause almost anything. All right. Endocarditis to your myocarditis to pericardial effusion and, ischemic heart disease and heart failure. Remember one thing, rheumatoid arthritis and psoriatic arthritis are independently associated with increased risk of having ischemic heart disease without anything else. All right. Rheumatoid arthritis and psoriatic arthritis has independent risk factor for developing ischemic heart disease. All right. Be very clear with that. Next thing, lungs, like I said, we already seen GI, splenomegaly, peripheral neuropathy can be there, mononeuritis multiplex can be there, carpal tunnel syndrome, spinal cord compression, and the most dreaded complication in neurological side, in the case of rheumatoid arthritis, is atlantoaxial subluxation. 3 days back, in the hospital where I go to see cases, and where I do see my neurology OPD there, one patient was no more because of atlantoaxial subluxation. She was admitted under neurosurgery. I don't know what went wrong. I just got to know she's no. She's a case of RA with atlantoaxial subluxation. It's a very dreaded complication. Then comes your Felty syndrome. Then renal, it can cause glomerulonephritis. Then it can cause secondary amyloidosis. All of you should know. These are the complications of rheumatoid arthritis. Next, can you guess what it is? Anybody? Of course, this is rheumatoid arthritis. What are you seeing here? What are you seeing here?
Aortic dissection.
Oh, dissection. What window is that? What window is that? What are you seeing there, doctor? What are you seeing here? Did we have a radiology lecture?
Lungs.
Yeah, that is lungs, of course. What is there? What are you seeing in this lungs? What are you seeing? What are you seeing? What are these things? What are you seeing? Okay, fibrosis is an acceptable DD. See the
Kaplan.
nodules. These are
Nodules.
there are nodules. See here. Can you see here? Can you see here? Can you see here? Can you see here? There are nodules. All right. There are nodules. Pulmonary nodules, maybe due to some inorganic dust exposure, plus rheumatoid arthritis is equal to what? Pulmonary nodules, especially in the peripheries with rheumatoid arthritis. Can someone think of some diagnosis that actually comes up? Anyone? 1, 2, 3, 4, 5 starts with the letter C. Now, this is for part 2 people. You will get a CT slice like this. You will have to diagnose. We are in the process of bringing India's #1 radiology lecture here for our MedExpert team. I have to go and talk to her. If she comes, it would be great. Excellent. Yes, this is Kaplan syndrome. All right, all of you got it. This is your Kaplan syndrome. Fantastic. Now, this is my patient with rheumatoid arthritis. You can see her hands. It's fully deformed. Myself, another faces candidate was there, and you can see the deformities in the hands. Right? Z lining is there. Swan neck is there. Hand muscles are wasted. This is a rheumatoid nodule in another patient. All right. This is a leg changes in a patient with rheumatoid arthritis. She has multiple changes. See here. This is another patient with rheumatoid arthritis in her legs. So now comes to criteria for rheumatoid arthritis. For all the 3 parts people, MRCP 1, 2, and PACES, nobody is going to mind if you know these numbers and all. All right. I want you to remember just 4 things in this table. Don't try to mug up so many things in the criteria. The very first thing I want you to remember is joint involvement. That's the first part. Number 2 is serology. Please remember CCP. Number 3 is acute phase reactants. Okay. And number 4 is duration of the symptoms. Is it less than 6 weeks or more than 6? This is 2020 ACR Euler classification of rheumatoid arthritis. And the score is 6. Duration is also based on 6 weeks, and the score is 6. 4 things. Just 1, 2, 3, 4. Joint involvement, serology, acute phase reactants, duration of the symptoms. Once again, joint involvement, serology, acute phase reactant, duration of the symptoms. More than 6 is a definite rheumatoid arthritis. Just remember that that's more than enough. All right, this is called disease activity scoring, DAS28 scoring for rheumatoid arthritis. Just to remember the name. Nobody is going to ask you to score this and come up there. Okay. All right. Then comes to investigations for rheumatoid arthritis. Extremely important. PACES people should know what you are doing and what you are doing for. All right. During my examination, examiner was very specific. There was a case of bronchiectasis. I started with complete blood count. He was like, be specific. Complete blood count. Why are you taking ABG? Why are you taking? What kind of respiratory failure you are going to get here? Come on, come on, come on. They were so much, kind of pushing me to the core. So you should know what investigation you are doing. Why? Full blood count. Check HB. Also, you can check for neutrophil count. You can check for thrombocytes. Neutrophil count to rule out FELT. All right, urinary examination to see any renal involvement. ESR and CRP will be raised. LFT, specifically low albumin level. RF positivity. What is the significance of RF positivity? It is not so specific, but it indicates the severity. If rheumatoid factor is positive, it's going to be a severe disease. And also, the patients who have rheumatoid factor positivity has a large extraarticular manifestations. All right. Next thing I want all of you to know is anti-CCP is the most specific and the most specific investigation in case of rheumatoid arthritis. All right. MCQ pointers. All right. This is an MCQ point. MCQ. ANA is positive in 30% of the patients. Then comes to X-ray in rheumatoid arthritis. Everyone should know, part 2 people, you will get an X-ray like this, or you will get an MRI like that, and you have seen the rheumatoid lesions, how it presents, you have seen the video as well. Now you must be definitely able to know it. First thing, periarticular osteopenia, symmetrical joint space loss. Can you see here? And deformities, these are the deformities, erosions, soft tissue swellings and nodules. These are the things you will find. Periarticular osteopenia, symmetrical joint space loss, deformities, your erosions, and your soft tissue swellings and nodules. All these things you will find in the radiograph of a rheumatoid arthritis patient. All right. Now comes next, another X-ray. This is the normal hand. This is a bony erosion you can find here. There is a bone displacement here. Again, erosions. Part 2 people, they will put this X-rays. You should be able to interpret it. We are trying our best to bring in the radiologist, because I am so convinced that the person which whom I am like feeling like she should come in for teach you the radiology should be the best bet for you all, especially coming to part 2 people. So we will try our best to bring the person so that you all can learn some radiology. If not, one of us have to step in. So these are the bony erosions. All right. Other investigations, you have to do ECG, you have to do your echocardiography. In respiratory system, you have to do oxygen saturation, ABG, chest X-ray, lung function test, and HRCT. GI is miscellaneous. So how do you manage? We have come to the last slide. How do you manage rheumatoid arthritis? All right. Remember, first case, in case of a mild disease activity at the time of presentation, and the patient is neither pregnant nor planning to be pregnant. So in that case, first 4 drugs, either HCQ, sulfasalazine, leflunomide, methotrexate with corticosteroids and NSAIDs. This is what BMJ recommends. Okay, British Medical Journal and plus British Society of Rheumatology. They recommend HCQ, sulfasalazine, leflunomide, and methotrexate. Any of this drug with a corticosteroid with NSAID if needed. All right. This depends on different patients, and different rheumatologists use different combinations of the above drug if there is a mild disease activity. The clinch here is it's not just about the disease activity they are worried about. They are more worried about one thing, that is, you should know the adverse drug reactions of all this drug. What are the adverse effects of HCQ? You should know. What are the adverse effects of sulfasalazine? You should know. What are the adverse effects of leflunomide? You should know. What are the adverse effects of methotrexate? What are the complications it can bring up? You should know. What are the adverse effects of corticosteroids? You should know. Because right now I don't have time to go ahead and teach everything, but you should know. That is the reason we are having a grand 10-day lecture series on clinical pharmacology, because clinical pharmacology covers up to 60% of your MCQs. If you are so strong in that, the chances of you passing MRCP part 1 especially will be really bright. So you should know the adverse effect of all this. That's your homework. You have to study HCQ, bullseye maculopathy, hypoglycemia. You should know methotrexate, bone marrow suppression, hypersensitivity, pneumonitis, all these things, steroids, myriad of complications, steroid-induced psychosis, to your infections, hypertension, hyperglycemia, osteoporosis, GERD, ulcers, all these things you should know. NSAID, same way you should know everything. So then only you will be in a much better position. So if you see, most of the questions that are going to be asked are based on clinical pharmacology, even if it is a cardiology, even if it is going to be a respiratory medicine question, it's going to be based on clinical pharmacology. So case 2, in case of a moderate to severe disease, and the patient is neither pregnant nor planning to be pregnant. Again, you start with methotrexate, sulfasalazine, HCQ, and leflunomide. Then you have to add up biologicals like etanercept, infliximab, adalimumab, certolizumab, abatacept, tocilizumab, and baricitinib. Every drug here is important, this list. This list, you should know the mechanism of action of all the drugs. Then the adverse effect, adverse drug reaction, you should know without failing in anything. You should know. And indications, what are the other indications? Baricitinib can be also given in your alopecia areata. Like this, you should know for everything. You should know the specific adverse effects. In a PACES examination in Hyderabad Center, They gave a case of infliximab induced ischemic heart disease which progressed to cardiomyopathy. This was the case. This was the case. When I was telling to some people, you should know the adverse effect, another patient's tutor came, hey, no, 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 why are you making people study this? Nobody will ask, nobody will ask. Exactly, they asked. In the next 2 days, the exam happened, they asked exactly. So you should be knowing this at this level itself. So you don't need to break your head when you are going to prepare for PACEs. You can spend more time in the bedside, seeing more patients and picking up signs and identifying signs and then presenting to each other, constructing some differentials. Okay. So this is very, very important. In case of a pregnancy or somebody planning for pregnancy, in Britain, Great Britain, United Kingdom, these are the three golden drugs: prednisolone, hydroxychloroquine, sulfasalazine. All right. These are the three drugs we prefer to give in case of a rheumatoid arthritis patient who is planning for pregnancy, planning to become pregnant. All right. Okay. That then comes at last is the complications. What are the complications? There can be work disability, requirement for surgery, carpal tunnel syndrome. You should know all the other causes of carpal tunnel syndrome: Cushing's, diabetes, your acromegaly, Felty syndrome. Okay, TNF alpha inhibitor related adverse effect, methotrexate induced adverse effect, or any biological and their adverse effect. Then pulmonary complications. Then, like I said, rheumatoid arthritis itself is an independent risk factor for ischemic heart disease. Always remember, okay? Itself is an independent risk factor for ischemic heart disease. So that completes our short discussion on rheumatoid arthritis. Thank you. Please like and subscribe us. Come to our WhatsApp groups. We can discuss more and let us know the topics or cases you find difficult. All right, please let me know. Okay, one doctor has requested Hep B and Hep C. I forgot his name. Doctor, are you here? Who requested me for Hep B and Hep C? If you are here, just say hi in the chat. Who has requested Hep B and Hep C? Are you here? Okay. If you're not here, we are going to do this. Again, that's to a very important topic. Okay. Hep B, Hep C. Immunocompromised patients, which drug to use? You have to start with something that doesn't play much with immunity, like hydroxychloroquine, sulfasalazine, you can start. But at one point of time, you have to give biologicals and monitor. Nothing else you have to do. You have to give the drug, monitor the drug, give the drug, monitor. The moment you find the adverse reaction is going to take place, like you're finding a decrease in count, you're finding decrease in neutrophils, then you have to stop the drug, give some drug break, then again start. Give some drug break, again start. Rheumatology is a never-ending cycle. If you go to the rheumatology wards, you can see people coming back, immunocompromised state. Even people who doesn't have any immunocompromised state, after started taking rheumatology, after started taking all these rheumatological drugs, they become immunocompromised, right? That's what happens. It's a never-ending cycle. So you give, monitor, then stop, then start. That's what you have to do. Safest, hydroxychloroquine. But the patient, once they become to a spectrum of immunocompromisation, then they will need a higher level drugs. Nothing we can do. And anyone else wants any other topic? My hospital right now, I'm in India. Like I'll be moving to UK in 3 to 4 months time, because I just like pushed away my my specialty training there for a little while due to some other personal issues. I'm in India right now. Like if you guys want to see or want to organize a PACES class or something like that, please let me know. Or any mock exams for PACES going people, we are more than happy to arrange for you. Okay, just let us know. You can join us in the evening times. All right. Morning time, there will be rounds. The only thing I don't invite people in the morning time is it's not just me. Consultants will be there. The senior professors will be there. It wouldn't be nice carrying 4 5 people or 5 6 people to go and examine patients. Evening time will be the best time. You can come, can see. We have good collection of neurology cases. We have valve replacement cases. Those things you can see. Pulmonology alone, I'm not taking anyone in because my immune system is not up to the mark. So I just avoid going and exposing myself to any open active tuberculosis, anything as such. Excuse me for that. Other cases you can see. Nephrology, if you want, we can go with all the protection because mostly they are fresh out renal transplant patients are there. So we have to be little careful when going and examining and touching them. Otherwise, fine. Alcoholic liver disease, you want to see liver and spleen, plenty are available. All right. Guys are most welcome. And thank you so much. Please let us know in the group how this lecture actually helps you. If it is helping you, we are going to have everyday discussion like this, 20 to 30 minutes every day, one small topic. Please leave your feedback in the WhatsApp group so that we will work out. And tomorrow we will see Hep B and Hep C. And all of you, whatever topics you guys feel it is difficult for you, only the clinical subjects. Please don't ask me anything that is not clinical, something like something involves this mathematics, biostatistics, please. All right. Anything clinical, if you find it difficult, you haven't seen some cases, you want to see some cases, okay, please let us know. We are more than happy to show you some of the videos. Because recently, yesterday, I happened to see a patient of Apert syndrome. A lot of people would have seen that. So all these things, please let us know. If you need any help in preparing for MRCP and you have some doubts on that, please let us know. We are more than happy to help you. Okay. Thank you so much for attending. Please leave your reviews in the group and please leave topics which you guys find difficult to understand. Leave at least 3-4 topics. We will see that in our everyday day-to-day interaction. Okay. Thank you so much. Bye bye for now. God bless you all. Bye bye.